Thank you again for this great presentation. And now we move to the cath lab for the next case. Are you ready in the cath lab?
Yeah, hi Giancarlo, how are you? So we have a wonderful case, again, keeping in context with the lecture and also trying to apply the data towards this type of difficult case. So Dr. Majid is going to present the case.
Hi, good morning, everybody. So this is a 73-year-old female with a history of hypertension, hyperlipidemia, and PAD. The patient has previously undergone left popliteal atherectomy, as well as supera and left peroneal atherectomy and a PTA. Now the patient presents with a severe non-healing ulcer at the tip and plantar aspect of the second right toe for the last couple of weeks. Rutherford grade 3, category 5, Fontaine 4. Next slide. The patient's past medical history includes hypertension, hyperlipidemia, intervention of the left leg in the past. Next slide, please. Next slide. She's on appropriate medications, including aspirin and Plavix, as well as a statin and beta blocker. Previous history of extensive smoking that she quit a while ago. Next slide, please. As you can see on her examination, the patient has an ulcer at the tip and plantar aspect of the right second toe. There's no gangrene. There are diminished pulses in the right lower extremity, 1+ in the DP and PT. Left lower extremity has normal pulses. The patient's laboratory data reveals normal values. Her right ABI is noted to be 0.35, and the left ABI is 0.9. Next slide. So here's the patient's angiogram. You can see that the iliac system is without significant disease. Next slide. Here's the runoff of the right leg. You can see that the proximal and mid SFA do not have any significant disease. The distal SFA is noted to have severe disease, followed by the P1 segment of the popliteal having significant disease. And then the P2 segment is occluded. I'll show you the distal pictures, but the PT takes off early from the popliteal segment and has good patent flow. The AT and peroneal reconstitute in the proximal segment. Next slide. This is a DSA image. You can see that the P2 segment of the popliteal is occluded. There's reconstitution at the AT and peroneal, and then the PT again has an early takeoff and is patent. Next slide. In the mid segment, you can see all three vessels with good flow and no significant stenosis. Next slide. Here's at the level of the foot. You can see that at the ankle, the distal AT has a severe stenosis, and then there is good flow into the DP. The PT in the foot is without significant disease. Next slide. So in summary, this is a 73-year-old female with a history of hypertension, hyperlipidemia, and PAD, who now presents with a non-healing ulcer at the tip and plantar aspect of the second right toe with an abnormal ABI of 0.35. Her peripheral angiogram reveals multivessel disease, including the distal SFA, popliteal segment, which is occluded, and severe infrapopliteal disease, especially the AT and peroneal segment. So the plan today is multi-level intervention. PK?
So as you guys can see, this is kind of fits right into what the talks have been about. So it's a very challenging case in the sense that a lot of levels of decision have to be made in terms of, first of all, how to cross this lesion. Second, what are the tools that you need to cross this lesion? Third, once you cross, how are you going to deal with the occluded popliteal? Fourth, how are you going to deal with the distal SFA, which is definitely stenotic and probably contributing to this? And fifth, how are you going to deal with the distal AT or the proximal, what's it called, dorsalis pedis? So the question becomes is, I think with this, we just wanted to show you what we didn't do much here, but I want to show you what's the diagnosis we've done. So let me show you here. Sorry about this. I should have been prepared. So we did a runoff of the SFA. You can see just to confirm he has mild moderate disease in the proximal. Mid-distal, you can see that the disease does become significantly worse with some significant stenosis at the proximal or the adductor canal and then into the popliteal. Distal, you can see here again, the popliteal occludes with collateralization occurring by the geniculates, and then you have formation of the anterior tibial artery. So I wasn't as convinced as Farhan that was a high takeoff posterior tibial. Personally, I'm not certain what that is. So at this stage, what we were going to do is we were going to go ahead and talk a little bit about or demonstrate crossing this lesion. And I think this is the wires. I think two things that we need to go over is what are the wire technologies and what are the things you can have. Here you can see the posterior tibia actually occludes, and then it comes back via collateralization. You can see here. And I was very surprised that he felt pulses because, as you can see, the flow is not the best to the foot. The other thing here, so what we normally do is obviously identify the cap very, very carefully. And you can see you have a cap. I don't want you to get fooled in thinking that there's a channel because that's actually a collateral. And what we normally do once we take our diagnostic is take a catheter with an angle. And this has really helped us. You can see the angle catheter right there to actually steer away from the collaterals. Hopefully I inject here. I know she was moving a little bit with pain. Nope, we didn't inject here either. Probably the next one. Here we go. So I can tell you, like when we injected, you can start to see a little bit more definition of what's happening to the vessel. And then we got down closer, and this is the most important thing for everybody out there, is you want to identify the cap and see what's coming out. And if you look at this, you have multiple collaterals coming out at the level of the cap, which is going to make it a little bit more difficult, and that's where a steerable catheter has helped. As far as wires, just to build on what Dr. DeRobertis was talking, we generally, if we don't identify calcium angiographically, we tend to go with hydrophilic wires. And if we identify calcium, our go-to is usually the Connect 250T. At this stage, angiographically, we fluorid. We didn't see much calcium, and I just want to show you on the fluoroscopy. As you can see, there is really not much calcium. I can just take a picture here to show you. It's very, very smooth, and I've just got that catheter parked in the cap. So at this stage, our wire choice, at least here at Giancarlo, is algorithmically, we just go with a hydrophilic type wire. Could be anything. We decided to go with an 018 tip load. We went with the Terumo gold tip. It's called the M, right? Terumo M wire. And then we use the 035 catheter as support. And we're likely going to track the catheter into the tibial if we're lucky enough to get through. So we're going to get started, and you guys could let me know what you would do. And then most importantly, I really need to know advice from our expert panel on how they would deal if we do we're lucky enough to cross this pop, how they would deal with the popliteal as well as the SFA. So we're just going to get started. I'm just start wiring.
So which will be the first guide wire that you intend to use?
The Terumo M wire, because of the fact that in our algorithm, since we don't have severe calcium here, we tend to go with a more hydrophilic wire to try to find the plane.
Is the PK, is it antegrade access you have? Maybe one of your partners can tell us while you're trying to wire. Is that antegrade access you have in the right or contralateral?
Up and over, contralateral.
PK.
Yep.
Hi, Stephen here from Singapore. I think that's a tough case you have there. Could I just ask if it's possible to give us an alternate projection of the popliteal artery showing the anterior tibial? Would that help you to decide on the movement of the wire and getting into the AT?
You know, Stephen, her creatinine is a little high, so that's why we didn't do it here. So I think I'm heading in the right direction. So what I'm going to do is I'm going to continue. I can show you the picture that we do have, and I want to show you exactly how it looks here. This is the actual angle of where it is. You can't even see the reconstitution. At this level, I want to just put this up. Maybe they can show this on the side while we wire this. Right here. You can see here, it's actually a good angle because I've been able to open up both the popliteal and the proximal or the distal popliteal with the anterior tibial coming off. So what I'm going to do is I'm actually just looking at the glow tape, and what I do in this kind of case is follow the glow tape straight down. And I know from anatomic, all of us know from just the anatomic, how this popliteal is going to run. It's going to run straight down that segment right into the anterior tibial. So that's the goal I have. So I'm going to have this saved up to the side of me, and I'm just going to use this as my landmark and just watch the movements of the wire. And here, Stephen, I'm pretty aggressive. So what I'll do is I will actually track my catheter in to give me support. I know that a lot of people use microcatheters, but in this situation, I think steerability is going to be important. I'm really hoping that I'm going to get really lucky and just pop right in. which I think I already crossed one area where you saw it pop into what I feel is a better lumen. So I think this may be hibernating in certain areas, even though we couldn't see it. I think there's a proximal occlusion, a hibernating segment, and a distal occlusion is what I really feel, because if you could see the popliteal, you could see the distal pop as the AT comes off, you see there's a little beak. So I think that little beak is the hibernating area of the distal popliteal, and we should be able to pop in that with a hydrophilic wire. So that's kind of my thought here. I don't know whether you use any different catheters, but that's what we use. But I think the real challenge, really more than crossing here, is what is the, how are we going to treat this?
So I'm going to let you work in peace here and ask somebody here. Miguel, so I would almost think of a different way to do this, maybe going antegrade and then taking, ballooning that SFA lesion first so that you could increase the flow and then take an 018 catheter down and then have a low threshold if you couldn't cross antegrade from going tibial, because that beak or hibernating area that he talked about looks pretty good for retrograde. What do you think access strategies, briefly while he's working?
Little resistance here.
Right, so as PK is working down that lesion, I'll tell you,
Nice
more
work
and more we find ourselves from the get-go, as we find a difficult anatomy, lots of collaterals from the stump or a complex multi-level disease. Honestly, I would just get my distal target vessel, which would be the anterior tibial potentially, and then do a retrograde access. At the same time, do an antegrade access of the common femoral and place a long sheath down to the popliteal. Now, obviously, PK is certainly making it look super easy, throwing all my comments down to the ground. But sometimes it's not that easy, and I would advise that you have to feel comfortable coming from below, because a lot of these things, what happens is you'll get yourself into a lot of the collaterals and really not make it into that one vessel that you're trying to get to.
So PK, you crossed it quicker than Miguel and I could talk about it.
No, but you know what? I really think, Chris, it fools you, because like Miguel was saying, I think there's two areas of occlusion here: the distal and the proximal ostium. And I think the steerable catheter helped us get through, and we're able to get it. And I think the hydrophilic wire. I know that there was a beautiful lecture by Brian that really helped us here, rather than go with a very stiff wire, which may cause dissection planes. So, I think with calcium, it makes it very, very difficult to decide which wire to go through. But when you don't have calcium, we tend to just go with hydrophilic wires, like the one we just used with the Terumo. But now the real challenge is, how do you treat? And I think it's also, the other question will be, should we IVUS or not, to give us an idea of fluoro?
I think that the technique you use is great, and that's exactly what I would do as well. And I think there's a real advantage to using an 035 catheter in these type of situations with an angle on it. And whether you use a CTO wire or a glide wire advantage or a command or hydrophilic wire, I think the trick that you did there is you engaged the lesion, you turned away from the collaterals, and you tried to pop through. I probably would have used a CTO wire, but I would have then only popped through about 1 centimeter before switching out to a hydrophilic wire at that point. And the other point I'd make about this is this could have been a very hard lesion to cross because of those collaterals coming off. So I typically would have a very low threshold after trying from above to go to exactly what Miguel said and use retrograde access. Retrograde access is sort of ideal for this type of lesion that ends in an occlusion that ends with collaterals.
Those are great comments too. PK, I got a question for you. George Adams here.
Hi, George.
Hey, PK. So, you're very well skilled. There's no question. In terms of the plaque morphology as you're crossing it, in terms of the wire feel, the catheter feel, do you think it was softer, or do you think it was harder in terms of the plaque morphology?
The initial part of it, IVUS, the initial part was really was difficult. As you saw, I don't know if you noticed, there was a little pop that occurred that allowed the wire to find that lumen. Once we got into that softer area or that hibernating lumen, what we did at that stage was able to advance it. But the key here is to make sure that you actually advance your catheter. A lot of people are worried about using 035 catheters. I mean, we've learned from Andre and other people that 035 catheters really work well below the knee. Right. And, especially you cutting it or shaping it to help you. So these vessels are 4 or 5 millimeter vessels, especially the popliteal, and even the proximal AT is likely a 4 vessel. So that catheter gives us that extra amount of pushability. And if you're having trouble breaking back into the true lumen, you can actually cut the catheter and then be able to direct it in. So to answer your question, I think there was a proximal cap, there was a distal cap, and an intermediate, lack of a better word, a hibernating vessel that was probably underfilled with collaterals.
Okay. Yeah,
So now, obviously, we dragged the 035 catheter down, so we're just going to do a quick IVUS. Go all the way to the AT, please. Okay. And you're going to see probably a lot more soft plaque than you thought. So all the way down? Okay, good. Let's pull back here. So this is intravascular ultrasound. All of you are well-versed. You can see the veins next to the arteries and all the collaterals because of the chronic occlusion. You can see as Dr. Kapoor pulls back, you can see some calcification, okay, diffuse calcified vessel, fibrocalcific plaque, and we're still not in the occluded segment. Now we're starting to get in the occluded segment. There you go. So George, to answer your question, it's really a fibrocalcific plaque, right guys? It looks like fibrocalcific plaque. And as we come out proximally, you really can see that, well, the lumen is created by the 035 catheter, but you can clearly see a diffuse plaque, which is pretty much around the catheter lumen. And I'm really curious to see the proximal. As we get into the popliteal, you can see more calcium, much more calcium proximally, and then you're now in the true lumen. So now the question is, now that we have IVUS diagnosis, the question would be, what's our definitive therapy here?
So PK, I think, so this is great. So now you have a three-dimensional view rather than a two-dimensional angiogram. You know exactly what type of plaque morphology you have. You can personalize your care and prep the vessel adequately. So in my opinion, if it were me, I'd probably use laser atherectomy because it's more of the homogeneous, heterogeneous type of plaque morphology to try to decrease my risk of throwing any emboli to adequately prep the vessel. How about the rest of the group?
Give me the directional.
I would agree with you. I do laser atherectomy, then POBA, then take a quick look, see, and then probably DCB plus minus bailout stenting with superior if you have a bad dissection.
And then how would you guys treat the proximal or the SFA disease?
I think one of the things your IVUS showed is that those SFA lesions, much of it at least, is not as bad as it looks. You know, and this is a CLI patient that if you have a 50% stenosis in the SFA, it may not be affecting your perfusion at the ankle or foot level. And so some of those lesions you may be able to just leave alone rather than having to stent the entire SFA or
I agree. I think the proximal lesions we were definitely planning on just leaving alone. But the distal vessel is right of the adductor canal and below is the area where we felt we're probably going to have to do something. So we talked about laser, but here we decided to go with the directional atherectomy because, again, the IVUS shows really, really well that it's mostly plaque. And we seem to have crossed pretty central luminally and without being in a dissection plane. I don't know if my IVUS team agrees with me. Guys, we're pretty luminal, right? Yes. Okay, good. So therefore, I think that at this stage, I'm just going to pass a directional atherectomy catheter. And what is this catheter, guys? This is the, which one? The Hawk 1S catheter. So I'm going to start proximally. And my hope here is to really try not to stent. And I wanted to ask the panel what their opinion of DCB in this area is. On, guys?
Some opinion. I wouldn't use a atherectomy device because we are not sure that they are really far away from the wall. So I wouldn't try to avoid a perforation. I would use a laser or go ahead just with a balloon. What is your opinion?
I think that's right. And the other thing is we also have focal force balloons. If you were are a little bit hesitant with atherectomy, you know, there's four currently on the market: Chocolate, Vascutract, Angiosculpt, and the cutting balloon. Ready? So if you were trying to modify the plaque to deliver biologic therapy, as Brian and Miguel were saying, that may be a reasonable option as well.
And I think your point is well taken with both the laser and or focal force. You really don't want to stent down the trifurcation if at all possible.
What's the vessel
so
size?
You're trying to get a good lumen without dissecting, and then add drug-coated balloon therapy. So, and this is one way to do it.
Can we see this last angel?
That looks beautiful.
Can we see again the last angel?
Yes, Dr. Bienvenido. No plus. So you can see here, Dr. Bienvenido, what we did was, because we felt we were not subintimal, we did 2 passes with the Silverhawk.
Okay, but you have a perfect daughter results already. So when you have already a perfect atherectomy result or daughter results, and you can go ahead with a balloon. Why to take the risk of a perforation, and particularly at the reconnection point at the bifurcation? It is, you have a very important stenosis of the truncus, and I would try to treat this before you may have a problem at the bifurcation.
So you're talking right about where the perineal takes off? You're worried about that? Right at the perineal, at that level?
Yeah.
So what we did was we measured this with the IVUS, and the IVUS showed that the proximal vessel was a 4.0, and that the distal vessel at the AT was a 3.5. So now what we're going to do is, I'm just going to save this next because of our chronic renal insufficiency. What we'll do is we'll just move this over, and I think we're going to stop this around 15 or so, and a little bit higher than that, and just do the straight segment with a chocolate balloon. The chocolate cutting balloon, I think the only thing that this has really shown us is that this is going to avoid dissections in the segment. And personally, I'm not certain that DCB is the right thing to do here. So my idea would be if I can get a nice result with great flow into the foot, I'd be very happy. So I'm going to stop right here, which is right at the level of where it takes off to become the anterior tibial, and do a prolonged balloon chocolate, and then see how we get. So this is a 4.0 chocolate, guys? Yes. It's a 4.0 chocolate balloon. And for those of you who don't know how the chocolate balloon works, this is a balloon that has, what length is this? 120. 120, wow. You guys went nuts. Oh, we did the so you're going to do proximal and distal, okay. So,
PK, as you're doing that, let me just say, to kind of support your decision process, I would have done exactly what you did there with, and that device is a perfectly sized device for that trifurcation. One thing I'll say is your IVUS showed that you were very clearly true luminal. Even if you weren't true luminal and if you were subintimal, I have very few concerns with using directional atherectomy, in part because you can direct it toward the side that you want to cut. You can direct it toward or away from the trifurcation. And so I've reconstructed many trifurcations with the benefit of being able to steer that cutter where you want it. The other nice thing about the device you chose is that you can use that for the tibial circulation. You can also use that for your distal SFA lesion with probably pretty good results. It's a little undersized for that distal SFA, but my guess is you'll be able to significantly change the SFA as well. So the only thing I would have done different, I probably would have done a few more passes with atherectomy, especially in the pop, and then re-IVUS just to make sure you're not getting too thin. And with IVUS, you can see when those cuts start getting a little thin, which you obviously know the ramifications of that from the paper you published on those deep cuts with atherectomy.
So at this stage, Brian, I mean, now that we've done a chocolate, do you use this in your practice, or does the panel use this in this kind of application? And if not, which kind of application do you guys use this in?
The chocolate balloon specifically? You know, I don't use that because one of the advantages of the chocolate balloon, the primary advantage in my eyes, is that it allows you to do balloon angioplasty without creating dissections. And I think that's probably generally agreed upon as the main benefit. The truth is I use atherectomy fairly routinely, excisional atherectomy, which allows me to sort of cut out those dissections with the device itself. So I haven't found a need for the chocolate balloon necessarily, but perhaps it's different with others on the panel here.
So if this looks good, say we don't have a dissection here, would you guys do drug-coated balloon here, or would you leave it with this, or would you recommend stenting this type of vessel?
I would like to intervene. My name is Theo Bistas from Münster, Germany. I congratulate you for this nice result. We have already published our results with directional atherectomy plus DCB versus DCB alone in Journal of Endovascular Therapy last year, with 29 patients included. And we've shown that the patency rate of directional atherectomy plus DCB were much better than DCB alone. So I will do it, and I think these patients had a Rutherford 4. That means you are not have any concern about the effect of paclitaxel to the wound. So I think it will be a nice idea to use DCB. Okay. So as far as DCB sizing, what size DCB would you choose? What size diameter, DCB? What diameter did you measure in the IVUS?
The IVUS, the distal was 3.5, proximal was 4. And you can see that we have a little bit of, I'd say, plaque shift into the proximal, which I'm going to have to balloon or stent with or do further atherectomy. So I'm going to do further atherectomy distally into the AT. But I'm curious on what type of DCB you would choose.
Can we see the bifurcation again of the tibialis anterior?
Right here.
Because it is not so
it's not
clear
good
for me.
I agree, sir. Inject. You'll see that there's a little bit of plaque shift at that area, or thrombus.
I am not sure that is the thrombus here. I have the marker of, it may be thrombus, but it's difficult to recognize for me.
So we're going to check at ACT right now just to make sure we're on heparin, and it may have actually thrombosed off. So what we're going to do is we're just going to do a quick atherectomy here, and I have a feeling that's probably plaque that's come down. So hopefully with the atherectomy it'll look better.
But it's your opinion. Do you have the impression that you have some thrombotic material there? And if you have to pass with the atherectomy device, then you have a probability to have an embolization of the tibialis anterior.
I think it's tricky, right? One of the issues in
personally, I would at this stage, okay, he passed already, so that's maybe the thrombus is already on the foot.
Torque it. Ready, a little more the other way. So it's important now to not cut with any bias. So I'm going to cut on this direction, on. Off. I'm going to just do one pass. Donde? On the right leg. Izquierda. Yep. Ready? Ready. Inject. So it's much better flow now in that area. So the question now is, she's moving because she's having pain in the foot. So the issue now is, as far as this is concerned, would you guys leave this, or should I do a DCB in this stage?
PK, I think it's wise to actually do an alternate projection of the trifurcation, because the bone overlies the origin of the AT. So I know she's got some renal impairment, but perhaps that'd be great if you could rotate it a little bit more to have both the fibularis and the tibia overlapping.
How's this right here, Stephen? Is this something you like?
Yep, that
looks beautiful.
Okay, tell her not to move.
PK, it also looked like that area of the AT origin was basically just beyond your chocolate balloon. And it may simply be vasospasm, and the thought of thrombus is another good thought. I probably would take a 3.5 balloon across that area, sort of bridge between the POP and the AT, although it does look pretty good at this point.
But now the flow looks much better, and I guess I think, Stephen, is this okay in terms of what you...
It looks great. I mean, I don't think that's...
Give me a 3.5 regular.
Perhaps we could have a look at the foot to make sure that she's not having pain from embolism, just to make sure.
3.20. Well, she's having pain in the foot, and so I think she's been having pain before we started.
Okay.
So therefore, I think this is just part of what she's going through. But now the question, I guess I'm trying to push and get an answer, is like a consensus from the panel in terms of what would your treatment? Would you do a DCB? Would you do a supera? Would you leave it with atherectomy POBA? Or would you, or that's it? I guess those are the choices.
One vote for DCB.
Yeah. You have two votes for DCB, but you'd have to be in the study. It's not FDA approved for the tibial vessels right now.
Yeah, PK, I think placing a stent in this region, this is where the anterior tibial comes out the sheath, so you got to be careful on that bend where you place a stent because of crush. So I would prefer not to place any scaffold.
You can use a 480, 100, put it a little bit into the AT.
Yeah, could you consider putting a 4, just keeping into the origin of the AT?
Definitely, it was 3.5, yeah.
I'd use a 4.0.
Here you go.
Yeah.
Maybe a low pressure 4 just into the AT, and then...
Give me a 4.0.
Pack that with
long DCB.
Overlap it with a whopping...
Is this a length of 4 centimeters, the balloon?
I'm sorry, sir?
It's a 4 centimeter long.
This is a 4-centimeter balloon, yes.
Yeah.
Just into the 3-5 40 balloon, just into the proximal anterior tibial artery, which is the artery of interest for this particular vessel. Down, or this particular ulcer. So I'm going to just go forward a little bit and just do a little bit more prolonged DCB. Go ahead here. I mean, prolonged POBA. Right
I have a small question. What is for you enough for after atherectomy? I mean, when are you stopping with the atherectomy? What is for you technical success for atherectomy?
You know, that's a question that I don't think anybody has a definitive answer. For us, I think the atherectomy is what we practiced is trying to debulk to the point of a residual stenosis less than 40%. I think that's the idea. And then we use IVUS to measure the vessel. Obviously, we're not able to direct in either way. Second is obviously floor characteristics. If we have good flow characteristics, then and we know that we're guttering into one side, especially with directional atherectomy, then we tend to stop. Down. 250? Yeah, give another, no, 500 of ACT. Okay, walk this out. Let's do a quick DSA, guys. I know creatinine's high.
There's a rule of thumb with atherectomy, especially excisional, you want to stop one cut before you perforate. That said, I would say that while that's not really feasible, IVUS is very helpful at figuring out, in my experience, when to stop, when you're done. And as I've used it more and more routinely, I've sort of come to
So now you can see the vessel is much larger and really good flow down to the foot. The only question now is I'm going to do DCB here, and I think I'm going to be done with this. I'm putting a 4-0 Lutonix DCB into the distal popliteal, into the proximal pop. The other question would be, how would you deal with that SFA? Obviously, especially in the adductor canal. Would that be another DCB, or would you guys do some other form of therapy like DES or Supera at that spot?
But can we see first the distal part to the foot, how the flow there is? Because
Sure.
I have the impression that you should maybe also treat the origin of the truncus, because they have a very tight stenosis there.
The origin of the dorsalis pedis?
Truncus tibiofibularis.
Oh, okay. Little dye here? I mean, no dye. Yep.
While you're positioning that, PK, in answer to your question, I think you've already got a chocolate balloon out. I think atherotomy and DCB of the distal SFA, and if you get a good result, you're done.
Yep.
That's what I would say. And then you can always stent with a Supera if you need to.
All right, so we're just going to go ahead now and just going to put up this DCB. Go forward a little bit. You want to go a little bit more? Yep.
I would like to ask Dr. De Robertis,
Go right,
have you
let's go
seen
right
any
here, yeah.
aneurysmatic degenerations after paclitaxel delivery post-atherectomy?
So I've not experienced any aneurysm formation after the combination therapy of DCB and atherectomy. I have, I believe it's 3 patients with ectasia of the vessel or aneurysm, early aneurysm formation. Each one of these 3 I've followed with duplex ultrasound. One of them now out to about 5 years. At the end of the procedure, or this first post-operative duplex at a distal SFA, there was about 1.3 centimeters, or maybe 1.2, around that. It's just stayed completely stable for 5 years. So I think it's a concern to follow if you see them, but I've had very few of them.
Is that a focal, secular-looking type of ectasia?
Yeah, just a little ectasia. In fact, one patient was very interesting. One of these 4 had bilateral SFA occlusions, used excisional atherectomy on both of those. He developed mirror image ectasia of the proximal SFA. It's very bizarre.
Same operator?
Pardon?
Same operator?
Yeah.
And you're saying with drug-coated balloons, as you're saying, directional with drug-coated balloons? Because it sort of makes sense, right?
I can propose that you show us the final result after a few talks.
So absolutely, Dr. Bimini. What we're going to do is we're going to go ahead, DCB this, take good pictures of the tibials, fix the SFA, and we'll show you the final results, sir.
Yeah, thank you.
Thank you.
Then,
Good case, guys.